So we have got a large number of questions sent in from you, and we will try to get to as many as we can. We've only got about 15 minutes in order to go through these list of questions. So I'll turn to Nathan. You have the first one on your docket.
All right. First question that I'll take a look at is explaining the relationship between scans and blood work. Scans being normal, but cancerous, say, being elevated. And one of those questions in regards to that is the relationship of tumor markers to imaging studies. So imaging studies sometimes can underestimate the presence of disease, but a tumor marker may be a little bit more sensitive indicator in some cases. And if it was elevated initially on presentation, sometimes that can be an early useful indicator of disease recurrence, and that can sometimes show up prior to imaging.
Mm-hmm. And the other part of that, which is the blood work, which are the tumor markers that we've talked about. Tumor markers can be affected by environmental and pharmacological factors. So while your scans can show that there is no evidence of disease and your tumor marker be elevated, it can be from a factor other than the actual tumor itself. So those kind of things we can repeat. We can look at what you are having in your medication list, and if there needs to be changes or medications that we can avoid using for a couple of days before you have your next test and repeat it.
All right, let me take a question. One is they hear about CT and MRs don't always show tumor spread for peritoneal dissemination, and that's absolutely true. And the analogy I like to give my patients is that if you took a grape and you hit it in the abdomen and you got a CAT scan or an MRI, a CT or an MRI would find it 100% of the time because it grows as a ball or a sphere. If you take 20 grapes, squash them and smear them on the inside of the lining, like you're painting the walls with it, a CAT scan and MRI will almost never show it until it's very late. And that's not that the scans are inappropriately read, it's the limitations of the technologies, which are much better at picking out spheres and three-dimensional subjects as opposed to plaques that grow on walls. So if you want to hide a gallon of paint in the room that you're sitting in, if you paint the walls with it, it'll be hard to find. If you leave it in the can, they'll find it every time.
I'd like to just, one of the questions had talked a little bit about different things for early detection of cancer that may be useful in the armament other than CT and some of the conventional tumor markers. And I just thought I would add to that the whole issue of ctDNA, because that is something that's becoming a little bit more prevalent. People are aware of it, know it's out there, and wondering whether or not that applies to their particular cancer. And making reference to some of the early ASCO meetings in 2024, in regards to metastatic appendiceal cancer, what they're finding is that it's not providing the level of sensitivity that we would like to see with appendiceal cancer. It's a little bit, the sensitivity is a little bit better with high-grade disease and not quite as good with low-grade disease. So in regards to ctDNA and appendiceal cancer, it's not as useful. It is a little bit more useful in metastatic colorectal cancer, and that's been employed, and it's starting to be incorporated in some of the algorithms for early detection.
Another one of the questions was if mucin is found in the colon after a mucinous neoplasm removed with appendectomy, could that lead to PMP? And the answer is actually yes, this can be a predictive factor as to whether or not you would develop PMP.
We also had a question there about what's the latest of Bromac. And for those who aren't familiar with it, Bromac is two drugs, bromelain and N-acetylcysteine, both of which dissolve mucus. So we've been trying to put together a research trial with our colleagues in Australia. Now, bromelain is an enzyme which comes from the stems of pineapples. And it's been a heck of a time getting this approved to do even the research trial. The goal of this is not a curative treatment. We can potentially inject some of this bromelain and N-acetylcysteine into the mucin, dissolve it so we can be now withdrawn out. Be drawn out with a needle or a catheter. It's still not approved. The FDA is done. We've been trying to bring this to research trial over the course of about 3 years with our colleagues in Australia. And what I can tell you is that the American FDA and the Australian FDA do not appear to get along very well. So the study is still not open, but we're still optimistic on it. We'd like to be able to run it. We'll be one of the North American sites when the time comes, but the answer is still not open, still hoping for it. And I'm waiting to get the thumbs up and the green light from our colleagues in Australia and the American FDA.
All right. One of the other questions, and I'm going to meld two questions together here, and that's how many patients have gone through HIPEC surgery more than 2 times, and discussing how many times a patient can undergo a HIPEC surgery with successful outcomes. Dr. Levine probably could give the actual number for us here as far as more than 2, but I've taken care of plenty of patients who have gone through more than, or at least 2 HIPEC surgeries. Which patients in particular are more likely to? Probably the low-grade appendiceal patients. And as in regards to the outcomes, a lot of that, it's a very nuanced question as far as burden of disease, aggressiveness of disease, and where that disease shows up, and how many previous surgeries patients had as far as making an additional surgery feasible outcome. I want to say that, if I remember correctly, is that I think the maximum number of HIPECs that we've had a patient go through was 4, yes, and we took care of that patient, and she did quite well, and but that's the maximum in our facility.
Mhm. And I'm going to go ahead and just bridge into, with all of the HIPEC surgeries, following a cytoreductive HIPEC surgery and chemotherapy, how many have dealt with gut/brain disorders? And are there any specific treatments that might be helpful? Your quote unquote gut disorders will be specifically related to how extensive your cytoreductive surgery is. In essence, if we have to remove bowel, small bowel, large bowel, that will affect your digestion and your elimination patterns. And we would work very hard with you to help you manage that. The HIPEC portion, the chemotherapy typically has very minimal side effects. So the brain fog that's typically associated with systemic chemotherapy is not normally a problem with the heated intraperitoneal chemotherapy.
All right. Next question we see is, what is the treatment for non-mucinous appendix cancer with signet rings? So appendix cancer, as rare as it is, comes in a number of varieties. The mucinous is the most common. The non-mucinous is less common. The treatment is going to be very similar in terms of the cytoreduction and HIPEC if you're eligible. Signet ring features are something important to note on your pathology examination. And again, one of the reasons I keep harping on, you have to get an expert pathologic opinion. That's really important. Signet ring features really don't mean much. They're going to be correlated with higher grade tumors. A signet ring cancer means 10% of the cancer cells have got the signet ring histology. That particular subtype is very aggressive. The treatment there usually is going to start, if it's spread to the peritoneum, with chemotherapy first for a few months, evaluate the response. If things look favorable, we'll take the patient to some sort of surgery, potentially a laparoscopic examination first to make sure that we have a good opportunity to get everything out. And if that's favorable, then take the patient to the full cytoreduction, usually with a HIPEC. So the treatment is very similar. It's really the non-mucinous cancer with signet ring features. That is a high-grade cancer, and it's treated very much like the other high-grade cancers that we see.
I'm going to take a stab at one of the questions here. My answer will probably be a little bit more on the general side, but it was in regards to our use of chemotherapy in the postoperative setting for appendix cancer. And kind of as a general rule, when you're dealing especially with a low-grade appendiceal cancer, once somebody's had a sufficient cytoreduction with the heated intraperitoneal chemotherapy, oftentimes that patient will move to surveillance if they've had a full cytoreduction due to the low-grade nature of the cancer. So chemotherapy really being more useful in cancers that are more actively replicating or high grade.
One of the things that I have is during the clinical trials, it says that my dad has low-grade appendix cancer surgery 9 months ago. However, mucin continues to develop. If this was your dad, what options or specific clinical trials would you recommend next? He is in the United States. And I would say that make sure that he has been evaluated by a surgery oncologist. He may qualify for a cytoreductive HIPEC therapy with a low-grade appendiceal neoplasm. The HIPEC is the primary treatment.
Next, we have a question about a watch and wait philosophy. After laminin is discovered following an appendectomy with no rupture when mucin is found at the resection margin. And the answer is a little bit complicated. We need to know a little bit more. Specifically, if there is no tumor spread in the peritoneal cavity and you have acellular mucin found outside of the appendix at the margin, you could potentially just watch and wait for those. The recurrence rate with acellular mucin in a non-ruptured tumor without peritoneal metastasis is actually pretty low. It's probably under 5%. If there is tumor at the margin, you can go back and just take out a little bit more of the part of the colon the appendix comes off of with a laparoscopic procedure to make sure the margins are clear. But the mucin, again, is not the problem. It's the cells that produce the mucin that's the problem. So the specific question is a good one. Unfortunately, to answer it, I think fully, you need some more medical records to know and a more complete consultation, but potentially watch and wait is not an unreasonable, depending on the rest of the details of that particular question.
One of the questions in regards to outcomes were, what are some of the commonalities that seem to exist among long-term survivors of appendiceal or peritoneal carcinomatosis? And I'll probably say of all the data that we have put out from our institution, bar none, the people that gain the longest survival are those with low-grade appendiceal who have had a complete cytoreduction. And those patients, that would be generally speaking the patients who will do, who have the longest overall survival.
Right. What are diet recommendations following treatment? And I'll combine it with the next question, which is any dietary changes you can make to extend your life with a LAMN or PMP, and which diet profile is best for long-term outcomes? Initially, after your HIPEC surgery, your diet is going to be smaller, more frequent meals until you reach your, as we like to say, your new normal, usually within about your 3 to 6 month post-op period. At that point in time, we would recommend that you increase your diet as tolerated. Our primary goal is to always make sure that you are well hydrated and that you have high quality nutrition with every meal. And we have provided multiple samples to our patients, and in the initial post-op period, you can utilize commercially prepared protein supplements that help to build your red blood cells and iron to assist with any problems of fatigue. And then after the time that there's not really a diet profile, there's no supplements, there's no specific diet, there's no foods to avoid specifically to help extend your life if you have any type of appendiceal neoplasm.
And there's a number of questions regarding chemotherapy in support of HIPEC procedures. And we've had a number of talks throughout the day today. But to give you the 40,000-foot view, for low-grade tumors, chemotherapy by vein is not particularly helpful. For high-grade tumors, it is. And one caution, the Hammond tumors, high-grade appendiceal mucinous neoplasms, are actually not technically cancers. Those are still technically benign tumors that can spread, and they tend not to respond. So it's labeled as high-grade appendiceal mucinous neoplasm, but is still would not even qualify as a low-grade cancer. So for those, I usually would not recommend chemotherapy by vein. I think we've got our video available.
We first met Jeff in September of 2017 when he was referred to us for stage 4 appendiceal cancer. Jeff was an otherwise healthy 45-year-old gentleman who was given the diagnosis of stage 4 appendiceal cancer, and he was referred to us in September of 2017. And we actually had to admit Jeff because he was dehydrated on his initial consultation visit. And once we had him hydrated, we had our nurse navigators set him up locally to stay. And within a week, we had him in an operating room. And Jeff underwent a pretty extensive cytoreductive surgery with heated intraperitoneal chemotherapy with mitomycin, also known as a HIPEC surgery. And it has been 6.5 years since Jeff underwent surgery. And we've been seeing him and had the pleasure of seeing him every 6 months since that time. And Jeff is here today for a follow-up visit, and we appreciate him taking the time to meet with us to share his story.
I started believing I had an ulcer, get an upset stomach every now and again, and just wouldn't feel real good. And it'd come and have a day or two, it just wouldn't feel right, and a few days I'd feel fine and that sort of deal. Tried a few changes in my life, and nothing ever seemed to really get much better. Finally went to a walk-in clinic, and the doctor there convinced me to get a CAT scan. Went down for the CAT scan, and they sent me straight to the emergency room. Said that I had several gallons, is the way they put it, of liquid or fluid in my abdomen, which turned out to be the mucin. They admitted me straight into a hospital and then proceeded to tell me I had cancer, and then to say, good luck, find a specialist. And pretty much everybody tended to say that I was inoperable and that I wouldn't survive the surgery. My options were find a place that would accept me, which we were pretty much told nobody was going to accept me as a patient. And so it was my only real option was hospice and to be sent home. That occurred about a week later. They just said either it was beyond skill sets of the surgeons or too brutal of a surgery, too far gone. And we came here, and lo and behold, met Dr. Levine, and that was 6.5 years ago. The surgery was good. It was long, I think. Woke up here. Great facility. I can't think of a better hospital to have gotten accepted to be in, to recover in. Everybody, and I mean all the way down to the person that came in, would empty the garbage can, was pleasant, friendly, talkative. I still remember the guy that would wheel me to scans and CAT scans and all, would sing. So that honestly mattered massively to me. Still friends with a lot of the nurses that took care of me. It just made it, I always felt like I was in good hands here. And that keeps me, very level, and I think mattered a lot to my recovery. We had a repeat surgery a week later for a bowel perforation. That wasn't fun, but went off without a hitch. Overall, I'm here, so can't be all that bad. It's not like having a broken arm where everybody gets wrapped in a cast, give it 4 to 6 weeks, you'll be fine. From what I've gathered, there is no two surgeries or recoveries that are even remotely close to each other. Listen to what your body wants, listen to what it hates, try and work with it as best you can, give it time. Getting back to traveling, getting back to fishing, getting outside to even golf. Riding a bike was huge and instrumental in my recovery. Just getting outside and walking was a big thing. So you find your wins where you can, and I think anything physically that you can do is going to pay itself off in dividends to you. I am thankful to every doctor that told me no to get here for the yes. And I'm, as dicey as it was, I can't imagine going through this with any other crew. And I'm not 100% sure I would have made it with any other crew. And as I said, that's coming from somebody that's fairly arrogant in that I always knew that I was going to make it, just didn't know with who. And that was early on. It was, to go back a little bit, it was August when they said, you have cancer and you won't make it 5 weeks. And it was September here, and my point was I'd make it to Christmas. And we're here. But that was less, looking back, having to do with my arrogance of that, as to the service, the care and the skill and everybody up here that we dealt with from the SECU house all the way through. Everybody that I dealt with here it's meant more to my recovery than anything. Thank you. Thank you for taking a chance on me. Thanks for always being there. The personalities, the attitudes, everything's just been, got no advice other than keep doing it. It's been amazing.
So I think we're going to move on to the remainder of the program. The next part of the program is going to be one led by Nathan regarding navigating tubes, lines, drains in the postoperative recovery period after HIPEC.
So cytoreductive surgery with HIPEC is a large undertaking with an equally large recovery, and most of this recovery will be able to take place in your own home. But that process will begin in the hospital, and there's a team of experts that play an important role in your recovery. And these include the surgeons, the APPs, the nurses, therapists, dietitians, and nursing assistants. And these patients, these will all take a key role in a patient's recovery. But some of the underappreciated assistance in the recovery process will be all the tubes and lines and drains that we use to closely monitor and support patients in their postoperative recovery. And this is often a feared part of surgery, waking up attached to all sorts of tubes and lines and drains, but their benefit is unmistakable. And with a little understanding of their purpose, hopefully we'll be able to better appreciate the role they provide, as well as we anticipate their quick departure. So when it comes to tube lines and drains, most of us have some familiarity with them from visiting family or friends in the hospital, or seeing them used on a television program or movie. But there's a lot of misunderstanding as to what they are and the role that they play in the recovery process. And some of the common questions that patients will have when they anticipate a surgery is, what can I expect when I wake up from surgery? And will I have, and you can fill in the blank, the type of tube or drain that they're concerned about having. They often want to know, why do I need all these devices? How long will I have them? And does having these tubes or lines mean that I need to stay in the hospital longer? Some important points to start with as we consider this, answering these questions, are that these types of tubes and lines are placed with intention by the surgeons, and often our preference is to avoid any of them if possible. They do not indicate that something went wrong during the surgery, but were put there very deliberately. We also understand that these are all temporary, and our intention is to remove each and every one of them once their job is complete in the recovery process. I think the best way to start thinking about these tube lines are to group them according to the role that they play in the recovery process. The three roles that we talk about are those that provide a supportive role, those that are there to monitor patients, and those that are there to manage something during the postoperative period. And you can see a list of all these. Some of them will play a dual role. The first category that we use is tubes that are used to support patients. And these, most patients are very familiar with. They expect to have them. These include the IV lines, or maybe if you have a portacath that was used for chemotherapy, we'll access that to give IV fluids and to hydrate. We additionally will use some sort of device for pain control early on in the postoperative period. And this includes PCAs, or as people refer to them as pain pumps, epidurals as well. Those are placed in the back and will also have a pump associated, and that allows the patient to provide pain control. The last of these supportive devices is feeding tubes. And sometimes we will place these, although most patients will not have them. But often if we do some sort of surgery involving the stomach as part of your HIPEC surgery, we often will have one of these tubes, and it allows us to get an early start on nutrition and get the recovery process going. The second category of tubes that we use are those that are used to monitor patients. And these are tubes that we put in to get a sneak peek into how the healing process is going in the abdomen or in the chest. These include JP drains, Duval drains, and sometimes we'll use chest tubes for these purposes. And these are tubes that are placed in the abdominal cavity or the chest cavity to monitor a surgical connection that was made or an area that we repaired in the process of removing tumor. And it allows us to monitor something in the abdomen or the chest while we have the patient closed up and recovering on the floor. The last category of tubes that we use are those that are there to manage. The body is always active, even in the early recovery process, and it continues to make digestive secretions and waste products and other inflammatory fluids that need to be managed in the initial postoperative period. And failing to do so would lead to discomfort or nausea and vomiting or other difficulties. And so these become vital in the recovery. And these include things like nasogastric tubes that are used to manage gastric secretions so a patient is not having nausea while we're waiting for the intestinal system to wake up. And they also allow us to rest the intestines while we allow for some healing time to take place. The next tube in this group would be like Foley catheters, and most patients will have these after surgery. Sometimes they'll additionally have ureteral stents in addition to the Foley, and those again are just there to monitor and to manage urine output while we are having a patient recover. And often once they're more mobile, we're able to remove these. And then lastly, chest tubes. And these, most patients will not have these, but again, they are the tube that is placed there to manage inflammatory fluid in the postoperative period. And once that process settles down, we are able to remove those types of devices. So a quick overview, of course, final thoughts. These surgical tubes and lines and drains play an important role in the recovery process, and as each one is removed, it marks a milestone in the recovery and moves you closer to discharge home. And I hope that understanding some of the roles that these tubes play in your recovery, that allows you to move forward with your surgery with less anticipation and fear. Thank you very much for allowing me to share.
Thank you, Nathan. That's a very nice piece. The next presentation is going to be from Dr. Carl Gray, who's one of our palliative care doctors. He's going to talk to you about how they can help the palliative care physicians.
Hello, my name is Dr. Carl Gray, and I'm the director of the Palliative Medicine program for the Southeast region of Atrium Health. Today I'd like to talk to you about palliative medicine, and the title is What It Is and How It Can Help with Your Cancer. So it's always good to start with a definition. So what is palliative care? Palliative care is a medical specialty that's focused on improving quality of life for patients and families facing serious illness. The emphasis is placed on communication, their symptom management, and their coordination of care. It's appropriate at any point in any serious illness and can be provided at the same time as treatment that is meant to cure that illness. Who are we? We are a team that consists of doctors, advanced practitioners such as nurse practitioners and physician assistants, pharmacists, nurses, social workers, and medical assistants who work together with your oncology team to provide you with comprehensive support. What to expect at your first visit? Our goal will be to get to know you as a person so we can learn how to best support you and your family. We will also work to address any symptoms related to your cancer. The most common symptoms include pain, nausea, fatigue, anxiety, and depression. And if needed, we're here to help guide any decisions you're facing related to your treatment plan, helping you align that plan with your goals and values. We really focus on the whole person, the emotional, physical, and spiritual well-being of that person, all of which also includes the main care partners for the patient, whether that person be a child, a spouse, or a parent. I want you to know that palliative care improves the quality of life and may actually help patients with incurable cancer live longer. So this was a crucial study that was completed about 15 years ago that helped put palliative medicine on the map in relation to collaborative cancer care. This study got palliative care involved in the clinic setting within 12 weeks of metastatic lung cancer diagnosis, which is typically incurable. The patients in the arm of the study that received early palliative care received all the usual cancer treatments and chemotherapies that the control arm of the study received, which did not include early palliative care. The results of the study found that those receiving early palliative care reported a better quality of life, particularly with less depression and anxiety. The patients and the families who received early palliative care also had a better understanding of the goals of treatment, especially when the patients had progression of their cancer. The early palliative care group was less likely to receive chemotherapy in the last 2 to 3 weeks of life, and they were also more likely to use hospice in their last few weeks of life. In addition to those important differences, what surprised everyone was that the patients in the early palliative care arm of the study lived about 4 months longer than those who did not receive palliative care. The study has affectionately been called the Temmel study over the past 15 years, which was named because it's named after the thoracic oncologist who led the study, Dr. Jennifer Temmel, who is currently at Mass General. After this study was reported, our field began work to better understand how we help patients who technically receive less chemotherapy near the end of life live better and even longer. Let's review a few concepts that help stress how we help people live better and sometimes even longer. A big point is that your functional status plays a large role in how you do with cancer and cancer treatment. So functional status is a fancy word for your strength and your ability to get around, as well as take care of yourself and participate in activities that are important to you, like your work, your hobbies, and your time with your family. The next principle I want you to know is that your symptom burden greatly affects your functional status. So the more symptoms you have from cancer and cancer treatment, which includes depression and anxiety, not just physical symptoms, the harder it is to be functional and to do the things that are important to you and your well-being. Many studies have found that involvement with palliative medicine leads to improving your pain, nausea, cough, sleep, depression, and anxiety, and many other symptoms. And this in turn leads to a better functional status that many people with serious illness would not have without palliative care in their corner. So overall, less symptom burden equals living better with cancer and with your cancer treatment. If you have less symptoms overall, you should have more energy to deal not only with your cancer and cancer treatment, but also more energy to do the things that you really want to do. And the impactful results from the Temmel study has led to many similar studies, including one that recently found that those receiving palliative medicine in the first year of diagnosis of lung cancer lived 10 months longer than those who did not receive palliative care in the first year of diagnosis. One benefit that can be hard to measure is we really want palliative clinic to be a place where you feel comfortable discussing your worries and concerns about your cancer. It's been shown through research that when patients are experiencing significant fatigue or depression, just for examples, they may not bring it up with their oncology team for fear of not receiving treatment. In those same studies, it was found that often palliative medicine created an environment in the clinic where the patient feels more comfortable bringing up those concerns. Now, of course, your oncologist wants to know about these issues so that he or she may be able to help, but it is what it is. Patients sometimes hide these symptoms just to ensure that they get treatment. A patient I have seen for a few years recently who was dealing with advanced prostate cancer was really tired and fatigued from his disease and disease treatments. He specifically told me he didn't want me to tell his oncologist. So we made a goal to work on it over the following month to help his symptoms. And luckily, we're able to help him feel significantly less tired in that time period. Some other important benefits of having palliative care in your corner are the following. Now, not all people will want or need help with the following issues, but we're here to guide you if needed. Of course, coping with cancer is something that some people may need some guidance on. Spiritual distress is another common symptom from feeling distance from their church, maybe because they're not around as many people as they used to be while they've had issues with their immune system and dealing with cancer treatment. Grief, and that might be confusing, but what I mean here is you can actually grieve the way things used to be. You can grieve the period before you had cancer, meaning I wish things used to be that way. I miss the way things used to be and wish I could get back to that time. Another one is adapting your approach to your favorite hobbies. So an example would be fishing. I've had a few patients that say they really miss getting down to the creek bed to do fly fishing. And they're so focused on that that they may not realize that they could go fish at the lake from the dock. Still get some of the things that they really enjoy from that hobby, maybe not exactly, but sometimes we can help them troubleshoot these hobbies that they miss. And then, of course, also talking to your family and even your children about having cancer and how to approach that with your loved ones. So in summary, palliative care is here to help you and your family by improving your symptoms, by hopefully also improving your function and functional status, and overall just help you live better. If you have any interest in being involved with palliative medicine, please just ask your oncology team, and we would be happy to assess how we can help you. Thank you.
Thank you, Dr. Gray. Next talk is on second opinions, research, and integrative health by Stephanie Thorpe.
I am going to be discussing research and integrative health in today's cancer care. Here at Atrium Health, we are fueled by the research of our NCI designated Atrium Health Wake Forest Baptist Comprehensive Cancer Center. We deliver care to cancer patients across the Carolinas as Atrium Health Levine Cancer Center. Today, the first thing we will be talking about are second opinions. A second opinion may reveal additional treatment options to your type and stage of cancer or confirm a current treatment approach. Second opinions, where to start? First of all, you should always ask your insurance provider to recommend a surgery oncologist specialist. You can search through this wonderful organization, the ACPMP. There is the Society of Surgical Oncology or the American Medical Association for specialists near you. You can also ask your doctor to recommend a specialist. Next, we would recommend that you schedule the visit with your second doctor. You sign the medical release form so that your records can be available on the day of your appointment. Consider getting a copy of your most recent CT scan, such as a disc and the report. Be sure it is available at the time of the second opinion visit. You can also ask about a pathological second opinion on biopsy results. Many second opinion center results make this request automatically. Give yourself enough time to arrange for your medical records to get there before your appointment starts. Check with your health insurance provider to make sure that the cost of the second opinion is covered, and prepare a list of questions that you would like to clarify at the time of the second opinion, because it's very easy to forget these when the visit starts. Accessing research trials, the goal of research is to find better ways to treat cancer. Cancer trials offer patients treatment options of new therapies or current therapies utilized in new ways. How to find treatment trials, you could search clinicaltrials.gov for the database of privately and publicly funded clinical studies conducted worldwide. You can join a national research registry, volunteers such as Research Match, and you can also visit the NIH All of Us research program, which is enrolling a large group of people that reflects the diversity of the United States. The benefits of a research trial would be medications are typically provided at no charge. Treatment response is part of that trial, and side effects are managed by the trials. Risk may be you could be given a placebo. Scans and labs for the treatment response may not be covered in the trial, and severe reactions could end your participation in the trial. Integrative medicine, where mind, body, and soul are taken care of. Integrative medicine is an approach to healthcare with focus on wellness as well as on treating your disease. It can combine conventional medicine with complementary treatments, takes into account the whole person, such as mind, body, and spirit, and emphasizes the therapeutic relationship. Integrative healthcare can include acupuncture, which can assist with treating pain, herbal medicines for digestive disorders, menopause symptoms, and pain, holistic psychotherapies such as hypnosis and hypnotherapy, culinary medicines, which use diet to address specific concerns and diseases. Those can include a vegan diet, a low-carb or carb-conscious diet, clean eating, and the Mediterranean diet. There's also yoga, Reiki, massage, and chiropractic therapies, along with Tai Chi, which utilize relaxation, breathing, stretching, and specific posture to address stress, pain, and more. Always discuss your integrative therapies with your surgeon, oncologist, and your primary care provider. The benefits can assist with stress management, provide improved nutrition and weight management, provide alternatives for pain medication, and improve posture and range of motion. The risks are traditional therapies can be complementary to the treatments and can have side effects. Therapies can cause medication reactions. Therapies can be costly and time-consuming, and therapies are not available in all areas or all seasons. Your treatment team is here to support you and to assist in providing you with the best care available. The references and websites are available on this slide. They include our organizational host, which is the acmpmp.org, the nah.gov, myclevelandclinic.org, cancer.gov, and the Alliance for Clinical Trials in Oncology.org. If you have any other questions, please visit these trials and they should be able to, or these websites, and they should be able to assist you with trials. Thank you.
Thank you, Stephanie. The next presentation is going to be on empowering patients and families during cancer treatment. This is by Cheryl Swiger, who's one of our physician's assistants here.
I'm Cheryl Swiger. I'm one of the PAs in surgical oncology at Atrium Health, Wake Forest Baptist, and I've had the privilege of working in the surgical oncology clinic alongside Dr. Levine, Stephanie, and Nathan, taking care of patients before and after surgery, as well as follow-up into survivorship clinic. I'd like to take a little time to share with you some important information that might be helpful to patients and families to optimize quality of life during treatment. Now, you might be asking, what exactly is quality of life? Well, it's really a concept, and it includes various aspects of being human, our physical, emotional, mental, spiritual, and social well-being, and taking into consideration our culture and our value systems. It goes beyond survival or cancer-free diagnosis. Even a person undergoing cancer treatment can be empowered and experience a good quality of life. This is enhanced when we have a strong social support, meaningful activities, and a positive outlook on life. There's so many different strategies, but I've touched on 5 here: education, communication, support services, self-management, and shared decision making. First, education. It's key for empowerment. Patients and families need to know the enemy, and that's why you're joining us today. Patients need to be informed about their diagnosis, treatment options, and potential side effects. Knowing these things can help patients choose options that align with their values and preferences. And we know that informed patients are more likely to be engaged in their treatment plans, leading to better adherence and ultimately improve outcome. Knowing what to expect can alleviate anxiety, helping patients feel more in control of their health journey. For example, if someone's getting a HIPEC and the expectation is they're going to stay one night, recover in 1 month, and have no side effects, patients and families will be greatly disappointed and discouraged. Number 2, communication. In addition to education, we encourage communication. It's important to have that open and honest discussion to ensure everyone on the patient's team is on the same page. Those difficult conversations have to take place and ultimately lets the patient know they are not alone. That said, some people would rather not discuss their diagnosis with others, and we should respect their wishes, but also encourage that communication. Here's a few suggestions listed that you can take a look at just to get the conversation started. All right, supportive services. Here are a few that you might already know. It's important to take advantage of these support groups, counseling, church resources, other more specific organizations. These can help patients and families start the education and communication steps, and so many opportunities for emotional and even financial support. Cancer support groups can help you feel better, feel more hopeful, and definitely not alone. Self-management. We could all benefit from basic self-care. And here's just a few suggestions to help reduce stress and anxiety that we all experience on a daily basis. But during cancer treatment, patients can focus on their health and make some important lifestyle changes, especially concerning diet and exercise, meditation, even sleep. I've listed some great health tracking apps that are free, and near and dear to my heart, of course, is the power of music. Anything that brings calm and joy to be pursued during this time. And again, I encourage support groups and peer networks for that emotional support and shared experiences. Lastly, shared decision making. Sharing the burden of making decisions removes barriers that inhibit treatment success. And so patients feel more empowered and engaged in their decisions for care. In the Cancer Center, we have something called the multidisciplinary team. In a family, it might be called the Come to Jesus meeting. For example, a patient or a family member may initially really push hard for aggressive treatment, but with the shared decision making, alternative options are brought to the table and evaluated. And throughout the decision making process, the patient plays a critical role in determining the extent to which the plan of care is likely to be effective, feasible, and compatible with their daily life. Having a game plan can give everyone peace of mind and help ensure the patient's wishes are honored and ease the burden on everyone. So hopefully I've offered some information regarding ways to help improve quality of life during cancer treatment. I encourage patients and families to consider these strategies that can create a supportive environment that enhance the overall well-being of everyone on the team, ultimately leading to patient fulfillment and excellent quality of life. Here's some contact information please feel free to reach out to me or Dr. Levine or Stephanie or Nathan if you have any questions or concerns. And all of the links will be at the end of this, and you'll have access to those. I think we'll have those posted for you. So take care of yourself and take care of each other.
Thank you, Cheryl. Our last talk for the regional session today is on nutritional considerations when CRS and HIPEC is not an option, by Monica Moorfield, who is one of our dietitians here.
Hi, I'm Monica Moorfield. I'm the dietitian. I work inpatient, and I work with a lot of HIPEC patients. And I'm going to talk about nutrition considerations when HIPEC is not an option. So first of all, if you're not having any problems tolerating food, then I just wanted to talk about some general guidelines that could be good for you. So eating a variety of fruits and vegetables, getting different colors to get different antioxidants and nutrients, eating whole grains, legumes, nuts, eggs, low-fat dairy, fatty fish is good. So twice weekly would be a good goal for the fatty fish. And then avoiding or limiting processed meats, red meats, no more than 18 ounces a week, which the size of a deck of cards is 3 ounces, to give you a reference. And then also limiting refined grain products, which would be like white bread, white pasta, white crackers, and then also limiting added sugars. And supplements may be helpful, like supplement drinks like Ensure or Boost. The Plus versions have more calories, or the Boost very high calorie has a lot of calories. Those can be helpful if you're having trouble with maintaining or gaining weight. Also, Orgain is another supplement that can be good. Premier Protein has a good amount of protein, doesn't have a lot of calories though. Also, if you're inpatient and you want to talk to a dietitian, then because you're struggling with eating or maintaining or gaining weight, then I or whoever, whatever floor you're on, the dietitian can talk to you. Or if you're outpatient, we have cancer center dietitians that can also talk to you. Just let your doctor know about that. And then if you do have a partial and small intestinal obstruction, then the first thing that I would do would be to limit insoluble fiber. So that would be like seeds and nuts and skins of fruits and vegetables and raw fruits and vegetables except bananas. If avoiding that diet doesn't help with an intestinal obstruction, then I would follow a soft diet, all the soft consistency, or if that doesn't work, then do pureed diet. If pureed doesn't help, you can't tolerate that, then a liquid diet. And then if you cannot tolerate even liquids, then alternate nutrition, which I'm going to talk about. So first of all, a soft diet, if the low insoluble fiber diet doesn't work, then a soft diet. So think of fork tender meats or vegetables where you can stick your fork easily into the meat or to the cooked vegetables, and that's pretty soft. So well-cooked vegetables, well-cooked fruits or soft fruits like bananas, eggs, yogurt, soups are all soft. And then also bread, soft breads. I wouldn't do like a bagel, but any other easily pulled apart bread. It would also be pretty soft. And then if soft diet is not enough, not able to tolerate, then I would go to a puree diet. So that would mean blending up your fruits, your vegetables, your meats, creamy nut butters. It basically, if you think of like baby food consistency, that's like pureed mashed potatoes, refried beans, hummus, all fits a puree diet. If you do not tolerate a puree diet, then I would go with a liquid diet. So a liquid diet, you can blend up solid foods, you can blend up meats and vegetables and use different liquids with it when you blend it up. So with meats and vegetables, vegetable juice, broth, gravies work well, milk even. And then with fruits, like fruit juice is a good liquid. And then if you are not able to tolerate anything by mouth, then and you have an intestinal blockage that's located closer to your stomach or in your stomach, or you have a stomach blockage, you're not able to tolerate food orally, then it is possible that you could get a feeding tube placed past your stomach, past the obstruction, if it's up close to your stomach, and then get nutrition that way. If you cannot tolerate tube feeding, or you have an intestinal blockage that is well past your stomach, so you have no room to really feed, then TPN, or total parenteral nutrition, is another way to get nutrition. It's broken down nutrients that are given through your veins instead of through your gastrointestinal system. Now, you may not have a blockage, an intestinal blockage, but you might still have some problems with abdominal fullness, nausea, diarrhea. So I want to talk to you about some ways to eat that may help with those symptoms. So if you are having abdominal fullness or bloating, then I would recommend making sure you're decreasing any gas forming foods, decreasing any way that you could swallow more air. So not chewing, talking while you're eating, not using a straw while you're drinking. Any gas forming foods that are typically cause gas for you. They can vary from person to person, but some typical ones would be like beans and cabbage and broccoli, but I would really hone in on what you have problems with. And then eating small, frequent meals and snacks may be helpful too. And then if you do have problems with nausea, I would try dry, starchy foods like crackers or toast, bland foods. Alternate your liquids from your solid foods. And then any liquids that are sugary, sweet, like regular juice or Gatorade, especially on an empty stomach, I would make sure that you dilute that. I would do like half water, half the sugary drink. And then don't take pills on an empty stomach unless you're supposed to, unless that's a medication that you really should be. And then if you're on any nausea medications, make sure you take it first time you notice nausea, or if you're taking it scheduled, just keep it scheduled. Rinse your mouth out with brush your teeth or rinse it out before you eat or drink might be helpful. Make sure you're hydrated well. Make sure that, that can be tricky if you're nauseated. You might have trouble with hydrating, but make sure that dehydration is not causing your nausea. So try to sip on a clear liquid every 15 to 20 minutes. And then if you're having problems with diarrhea, a few things that may be helpful: eat small, frequent meals and snacks, so like 6 times a day or so. Consume your liquids more in between your meals, less at the same time with your meals, just to help slow things down. Like waiting an hour to drink a lot of fluids, but limiting to a half a cup or less at the same time that you eat solid foods. Make sure that if you're doing any sugar-free foods, that you are not doing any foods that have sugar alcohols, which would be like xylitol, sorbitol, maltitol, mannitol. Also sorbitol containing fruits like peaches and pears and pineapple, be good to limit if you're having diarrhea. And then sugar also can be a potential problem. So just avoiding sugary drinks and foods may be helpful. And then also really fatty foods like greasy fried foods, foods that have a lot of oils, cream, a lot of cheese. They may be hard for you, might be causing diarrhea. So I would just decrease that. Eating bland, starchy foods like white rice, oatmeal, bananas, toast, mashed potatoes, crackers, those things can be good. And then if maybe lactose is a problem for you, so you can get lactase, which is the enzyme that you can get that over the counter and take that with dairy, or get the dairy items that already have the enzyme in them, like Lactaid items. They have the Lactaid name on them. Those also have the lactase enzyme added to the dairy. So those are just some things that you may try that may be helpful. Hope this is helpful. Thank you for your time.
All right, I think that's the end of our regional session. I'd like to thank all of you for joining us today. Thank everyone on the panel. I'd also like to thank Jenny Kong, who's out of camera, but has been crucial in terms of making everything work today. thank you for the support of the ACPMP. And if you have any further questions, reach out to us. We're going to have this posted hopefully within a few hours. Thank you very much. Good afternoon.
Thanks, Dr. Levine. Thanks, everyone at Atrium Health. Have a good night.